going to talk a little bit about brain abscesses, meningitis, and encephalitis. And, of course, you know, all sorts of things can happen to your brain. We can have bacterial infections, viral, fungal, protozoan. The ones we usually see are bacterial and viral. However, I have seen some fungal and protozoan things. So those can happen. But the inflammation is from the meninges of the brain and in the spinal cord as well. And certainly the bacterial is by far the most dangerous, and it is a medical emergency. You can die from it, and it's very contagious as well. Now, the viral is a self-limiting, and usually the patient has a complete recovery. It's not usually life-threatening. Certainly, we remember that the entry routes of bloodborne things are through the blood-brain barrier into the central nervous system. Direct injury can be through a trauma or surgery or what have you. Can also be through sinus infection, pimple, that kind of thing. So very often those things can happen. Now the viral usually has some predisposing condition like measles, mumps, herpes, what have you. So, but I want to say that in a rare instances, tongue piercings have been associated with meningitis. I'm just saying. Just thought you'd want to know. Certainly we know what exudate is. That's where there's pus running amok up in your head, and that's not a good thing. These are some of the classic signs of meningitis. Nuchal rigidity. Remember, that is your neck being rigid, painful to move in it. Burdinsky's sign and Koenig's sign. I'll go over those in a second. I know you already know them, and photophobia, phonophobia as well. So other signs we may see are chills and fever, and the heart rate elevated, headache, chills, nausea, vomiting, and seizures, all bad things. And usually those will appear first, and then they will sneak on into confusion and stupor and semi-comatoseness. Those are certainly later symptoms. But meningitis is a tricky business. It can be, just puny right now, and then in a couple of hours, you can be at the point of death, and particularly with children and young people or the elderly. So have to be pretty vigilant watching for that. And also say that we need to encourage people that live in close quarters, like the military, or people in dorms, or congested areas, or what have you, need to get vaccinated. That makes sense, doesn't it? Now, encephalitis itself is the inflammation of the tissue, the brain tissue, and the spinal cord, or the parenchyma, which is just a 50-cent word for tissue. And we can see that often these can be transmitted by the ticks and the mosquitoes, like the sleeping sickness and what have you, the West Nile. Herpes also can be one of those. And like I mentioned earlier, the measles, mumps, chicken pops. That's what my little nephew used to call them, chicken pops. Okay. Let's see. Yeah, these are still manifestations. They look the very same, don't they? Nuchal rigidity, change in the level of consciousness, getting a little fuzzy and disoriented, agitated. They can be restless or lethargic, photophobia, phonophobia, nausea and vomiting. Okay. Here's the Burdinsky sign. I knew it was in here somewhere. The client laying on his back. You lift the head up from the bed, and if it's positive, they will have their uh, flexion of both thighs will happen. And they'll also have flexion of the ankles and the knees. That's the Brudinskis. And then with Kernigs, they're also laying on their back, and you flex the thigh at a right angle to the abdomen and extend the leg upward, and the patient will have a lot of pain and spasm in the hamstring and resistance to further extension. So that's Kernigs. That's telling you they've got meninges and all irritated. Okay? So we want to figure out what's going on, isolate whatever's growing so that we can take care of it, give them the correct drugs to take care of it. Bacteria certainly is very contagious and the most dangerous. The antibiotics we usually give for that are the rifampin, Cipro. Those are kind of big guns, and they're also broad spectrum. So anticonvulsants, because we don't want the patient starting. We know when you got your meninges and all irritated, you are higher prone. Your threshold to seizures is lowered. So fluid and electrolyte replacements, possibly do some testing for the increased intracranial pressure, but probably what we'll do mostly is just monitor for it, not actually monitor the pressure readings themselves. Provide a quiet environment, lights kind of lower, keep stimulation down, noise down, because those are so painful for the patient. And initially they may avoid giving analgesics because of masking the central nervous system, but then eventually they probably will give, once they know what they're up against, they probably will give medication to help in that area. Now, brain abscess, I don't know how that got down here. But okay. Anyway, we've got either have a closed off area, encapsulated area in the brain tissue, or it's just free out there, open abscess in the brain. It can be either way. Usually, though, these are bacterial, and there's usually more than one. It's not just usually one little spot. It's usually kind of a mass of places. And it can be a complication from meningitis, and then it's kind of walled off and causes some little bad places. Often we get these in the frontal and the temporal lobes. But look at this mortality rate, 30 to 60% mortality rate. And of the maybe 40 to 70% that might survive it, they will have 30% will have neurological deficits. So they never quite go back to where they were, some of them. So that's not a good thing. So we want to find it, as quickly as we can and treat it, and make sure that they're getting the antibiotic that they need, and that we're giving them the best care that they can possibly get. Look at when they have an abscess, same symptoms that we saw before, so it might be a little hard to distinguish. Headache, lethargy, drowsiness, confusion, level of consciousness decreased, and they may have the symptoms of an infection, chills and fever, certainly. So we'll give them combinations of medications, give them probably a combo of antibiotics, as we often do, because we find that works better. And you can see we've got penicillin, nafcillin, flagyl, and vanco for the anaerobic organisms, anti-epileptics, analgesics. Might even do surgery and clean out the abscess, wash it out, drain it, and everything. Again, the same clinical manifestations. This is going back to the LPs and all, very same, bacterial, viral. Very same thing. The end. Thank y'all for hanging with me. See you this week.